Hello and welcome to our discussion on the Rural Health Clinic Productivity Standard Exceptions. For an agenda, we are going to be talking about just the cost report flow related to the general productivity standards, and then we will talk about the exception process, the overview. We will go through the productivity standard exceptions checklist, and then finally we will discuss the recent COVID-19 exception that is in place for these standards. So first of all, let's talk about the RHC Productivity Standard Cost Report flow. This starts out on worksheet M-2 of the cost report, specifically with lines 1, 2, and 3, including any subunits of those 3 lines. Now, you see here that line 1 represents the physicians, and then lines 2 and 3 are both what are known as mid-level practitioners, which include the physician's assistant, the nurse practitioners, and potentially other professionals. So again, those 3 lines can be subscripted if you have more than one of those professionals. So what happens here is with those 3 lines, you'll notice we have a variety of columns. We have number 1, which reflects the number of FTEs for that particular type of position. And notice it could be less than 1, it could be more than 1. It's rounded to 2 decimal places. So we have the number of FTE personnel. We have the number of visits that were handled by that particular physician or physician assistant, whatever the personnel was. So number of visits. Now notice this is during that cost reporting period. So the number of visits handled during that cost reporting period. And then number 3 is the productivity standard itself. By default, this will be 4,200 for any of the physicians in line 1 or subscripts, and it will be 2,100 per FTE for lines 2 and 3 and any of their subscripts. So the mid-level practitioners will show 2,100 required visits throughout the year. That's the productivity standard. That's the minimum that are expected for one FTE. So what will happen here is column 4 multiplies the number of FTEs by that productivity standard. So as you see with the physician, we had 2.1 FTEs multiplied by the 4,200 per FTE. That shows us that we have a minimum visit amount of 8,820. Now, that'll be calculated for each of the lines here. Now notice this is compared back to the actual total visits on column 2. Now notice this was an example, a rather extreme example, showing that for this particular year there were 2.10 physicians, and combined they handled 150 visits. However, the recommended minimum, the standard, so to speak, was 8,820. So what's going to happen is that's going to be bumped up to 8,820. Now notice there's nothing in column 4 by line. However, it all factors into the total of line 4, column 5. So with the physician assistant, there were 0.65 FTE. Total visits of 1,229. There was an expected minimum visit count of 1,365. So they were just slightly under the required visit count. And the nurse practitioner, they had 500 visits. They were expected to have 2,310 visits that year. So again, all 3 of these lines in this example were below the minimum visit count. So in total, they only had 1,879 visits. They were required to have 12,495 visits. So this higher number of visits is going to be carried forward to M-3, as opposed to the actual visits of 1,879. Now keep in mind, these are total visits. So what is happening on worksheet M-3 is that the cost, the adjusted cost, is being divided by those visits to identify a cost per visit. The cost is not a part of this process. We're not doing any sort of revision to this cost. It's only the number of visits that are being impacted. So when we divide this 413,000 by 12,495 visits, that adjusted visit count, we get an adjusted cost per visit of only $33. If this were instead divided by the 1,879 visits, this would be a much higher adjusted cost per visit. So this just goes to show that being subject to the RHC productivity standards and being under those standards, so not having achieved those standards, will result in the cost per visit dropping when the standards are applied. So this reduces the cost per visit, which is ultimately going to reduce the reimbursement for this clinic. So the cost per visit is diluted. That's another way of saying that. Now, there is one last piece of the cost report flow that's important leading into the exception itself. Worksheet S-8 deals with the exception. Line 12 specifically says, have you received an approval for the exception to the productivity standard? Yes or no? It's column 1. The only way that 4,200 and 2,100 can be adjusted is if there is a yes in this column. Otherwise, there will be an edit on the cost report. So if you've been approved for an exception to the productivity standard, enter yes. Now, I do want to mention one other thing about this. You can also enter yes if you have a non-standard cost reporting period. For example, if you only have a 6-month cost reporting period, then you would want to adjust this, first of all, to yes, to show there's an exception. And then since it was half of a year, you'd want to revise these standards to 1/2 as well. So the 4,200 would drop to 2,100. The 2,100 would drop to 1,050 for the standard. That way everything would be matched up with the cost reporting period. So now let's talk a little bit about the overview of the exception process itself. So CMS Publication 100-02, Chapter 13, Section 80.4, this creates the standard exception process. And you'll notice here, it gives a little overview of what the exception is, first of all, or what the standard is. And then it mentions that the MAC has the discretion to make an exception to the productivity standards based on individual circumstances. It stops short of providing examples for those standards for what would justify a standard exception. We have some more information on our website. As you'll see here, you'll see the link to that website. And we have some of the overview. We point to the manual, but we also point to an old Federal Register from 1982 that really created this standard exception. Now, it gives some examples for when this standard exception may be justified, but it's not all inclusive. You can see here it's basically talking about the standard itself, and they give as an example, for example, if a clinic could demonstrate to the carrier, which is now the MAC in this case, that it employs no more than the minimum number of staff necessary to meet applicable certification requirements, but nevertheless is unable to furnish the expected number of visits, the MAC will not apply the productivity guidelines in calculating the all-inclusive rate for the clinic. So that's the extent of the information that's provided. The rest of it is at the discretion of the MAC. So to assist with these requests and the reviews, we've generated a standard exception checklist for these. Now, one thing I do want to mention is that there is no policy-driven time frame for these. Unlike many other requests, such as statistical basis changes, cost center changes, this particular one does not have a particular time period. We recommend that you submit the request prior to about 60 days before you submit the cost report in order for us to be able to review it and get back to you in time. Now, that's not a requirement by any means. Even if you submit the cost report without any information on the exception, we can still handle that through the desk review. We can handle it potentially through a reopening down the road. So again, there's no time frame for those. But one thing I will mention is that in most cases, it's recommended that the cost report period be completed or very nearly completed by the time you submit this, because as we'll see with the checklist, we are asking for information about that cost reporting period, the actual number of FTEs, the actual number of visits, and that generally wouldn't be available until the cost reporting period was over. There is an exception to that I'll talk about at the end of this discussion, but for the most part, we'd prefer that be after the cost reporting period is over. Now, as far as submission of these requests, we prefer these via email to our audit advisement. So it's audit.advisement@wpsic.com. If for some reason you do need to send it hard copy, you can send it to me at the below address, and I will receive it that way, and we can start our reviews. So the next thing I wanted to do is go through the actual checklist itself. And this is a spreadsheet that was linked. In fact, let me show you. It's linked right here in our website article. So the very first portion of this is, again, just some background information. You can read through that. It's a little bit of training information there. It also talks about the cost report flow. The first portion that you would input provides information about both the hospital as well as the RHC. So a couple of things I want to mention here. We do need to know the main hospital name and number. That is how we file the requests. So when the desk review is performed on that particular unit, we'll know what hospital it was and whatever RHCs might have been underneath of it. There should be a separate tab completed if you have more than one clinic, because again, the information is going to be different. We'll need to know the impacted fiscal year end or potentially fiscal year ends, plural. We need to know the city and county that the RHC is located in and the date of submission of the request. Again, there's no time frame requirement for that. We just need to know when it was submitted. Continuing on, we get to the information about the FTEs and visits for this cost reporting period. So notice that by default it has line 1, 2, and 3. But again, you can add additional lines if you've subscripted those lines, if you have more than one physician, more than one type of mid-level practitioner. You can certainly subscript those just by adding a line. We need to know what FTEs, what number of FTEs you had, and what the total visits were. Question 2 is the same information about the prior year. So we're taking a look to see what types of increases existed. For example, if the physician staffing doubled without any good justification, and now all of a sudden that clinic is unable to meet the standard, that might cause questions. They were able to meet the standard last year with 1.5 FTEs, and now they have 3 FTEs, and now they're under the standard. Again, that might be questionable there without other justification to support it. So that's what we're looking for in number 2. And number 3. So by this point, you already know your number of visits. So we're asking, what visit count are you requesting as an exception to the standards? So in other words, instead of 4,200, what do you believe is a valid standard for this particular year based on the justifications that come in the next step? And then we get to questions 4 through 8, which are the justifications. Now, as this says, you only need to complete the ones that relate to your request. Again, what justifies your request to begin with. You don't need to fill everything out. So number 4, explain and demonstrate whether the clinic employs no more than the minimum number of staff, physician, and mid-level practitioners necessary to meet applicable certification requirements. Include details on what the current staffing level is and what the minimum requirements are. So in this case, if the facility is already operating at the bare minimum to meet the certification requirements and they still can't hit the standard, that's a pretty good justification generally for that standard. We couldn't recommend that you drop below that number of FTEs because you'd no longer be in compliance with the certification requirements. That's what we're saying there. So number 4 comes first for a reason, because if you meet that, the rest of them might not be relevant. Number 5 is really just informational. It's not so much a justification because by definition, all RHCs have to be in some sort of shortage area just to be an RHC to begin with. But this just helps to explain what type of shortage area the facility is in. So number 5 by itself is not going to be sufficient. Number 6, in some cases, an RHC may be located in a very small area with a small population base, and if it's significantly lower than what would reasonably be needed to generate the minimum number of visits, this might be justification for an exception standard, a standard exception. Now, as mentioned here, this generally requires evidence for number 4 as well. If it's in a very, very small area, then you'd want to see how many FTEs were employed by that clinic. And if they have more than are reasonably needed for such a small population base, that may call that into question as well. Number 7 is a completely separate one. Document whether any new physicians or mid-level practitioners were added during the cost reporting period in question and when they started. And then explain why you believe this may require a temporary reduction to the RHC productivity standards. And the key word there is temporary. There might be situations where there's turnover in the facility. Even that Federal Register that I cited earlier from 1982, that does discuss the potential for turnover and how that may cause a temporary decrease to the number of patients that come to that clinic. There might be a relationship building phase. So things like that might help to justify your request, again, on a temporary basis. And then number 8, explain and document any other justification for an exception. I will mention this one will become important in this next slide because we have a certain temporary exception that's in place right now that's not listed in any other step of this checklist, so I would suggest using number 8. We'll get back to that in just a second. And then, again, we want the name and title of submitter and the date submitted. So the exception I was alluding to relates to the current COVID-19 pandemic. So there was a document, a MedLearns Matters article issued by CMS on July 2nd, and I have the link up here if you wanted to find that. I also have the information copied here. So it basically says, it discusses the RHC productivity standard itself, and then the last paragraph says many RHCs have had to change the way they staff their clinics and bill for RHCs during the COVID-19 public health emergency. As a result, these RHCs may have difficulty in meeting the productivity standards. To minimize the burden on RHCs, exceptions to the productivity standard may be granted by your MAC during the COVID-19 PHE. Further direction will be forthcoming from your MAC. And as far as that, WPS did send out letters to all RHCs with this information. We've also posted this on our website. And of course, we're communicating it through this video right now. So what this is basically saying is that we understand that an RHC may have a significant drop in visits. There may be changes for a variety of reasons in the visits. A lot of times it could be a drop due to the fact that patients are not willing to come to the clinic at this point for the public health emergency reasons. So for these reasons, if you're experiencing these situations, feel free to send us a request. Again, go ahead and use the checklist and basically use that last justification. Just type in some information about what you're experiencing with the COVID pandemic, the PHE, and then we can review that. So that takes us to the end of our discussion on the RHC productivity standard exception process. If you do have any questions, please feel free to send those in to that same email address I mentioned earlier. And thank you for your time.